I'm just going to give a brief talk about kind of overview of menopause and the management of its symptoms. So I decided to start off with a history of menopause. Obviously, menopause has been around as long as women have, but there's mentions of it even back in ancient Greek times. And Aristotle makes reference to the age women are noted to stop menstruating, that they're no longer able to become pregnant. The term menopause is coined by a French physician in 1821. And in the 1800s, there's lots of lovely literature from doctors describing the climacteric insanity that affects women in this stage of life. And it's the most grave of conditions, and women have an inattention to their domestic affairs and are afraid of an unknown evil. In the late 19th century, there's early trials of menopause therapy, and women are given ground up cow and pork ovarian tissue to treat their symptoms. And then the 1940s is the dawn of HRT. And although there's questionable advertising campaigns such as "Please Keep Her This Way" and "Husbands Like It Too," women now have an effective treatment for managing their symptoms. The growth of HRT is exponential, and by the 1990s, it's one of the most prescribed medications in America. Unfortunately, that all changes in 2002. The Women's Health Initiative study, one of the largest studies at that time looking at the effects of HRT, releases its initial results. And worryingly, it shows an increased incidence of breast cancer, blood clots, and heart disease in women taking HRT. And understandably then, the media go crazy with headlines, and there's a lot of fear, and suddenly we're not prescribing HRT anymore. In fact, between 2003 and 2007, the use of HRT is halved in most countries. Over years, that data is reanalyzed, long-term follow-ups released, more and more studies are done. And actually, the reality isn't as bad as that. And I'm going to come on to that at the end of my slide. But things change. The HRT, menopause, starts being talked about again. And I decided to look at Google searches in Ireland from 2004 up till present. And you can see there's a steady increase over time. And then we get this sharp peak recently. And that coincides with a certain week in May 2021 when the cultural phenomenon of Joe Duffy and Davina McCall coincide. Davina releases her documentary, Sex, Myths and Menopause. And Joe Duffy has an entire week of Liveline inundated with calls from women about their menopause experience. So I thought, well, what were people Googling? Apart from how old is Davina and what is she using, I thought, well, what is menopause? How do I know I'm menopausal? What are the symptoms of menopause? And how do I treat my menopause? So what is menopause? Menopause is a woman's last period. The average age in Ireland is 51. We can't say a woman has had her last period until she's been 12 months without bleeding. The symptoms often start many years before this due to changes in hormone levels. And there's some subtypes of menopause. We talk about premature ovarian insufficiency, menopause in women under the age of 40, early menopause between the age of 40 and 45, surgical and medical menopause, where menopause is brought on either by surgery, such as removing a woman's ovaries, or medication, certain cancer treatments. This is kind of a hormone life in a woman. So menarche, that's the age we are when our periods first start. And then we have premenopause, or our reproductive years. We have the hormonal transition of perimenopause, then we have menopause, and then that leads us into postmenopause. And these are our hormones. So in our reproductive years, you can see that cyclical pattern in estrogen and progesterone. So that coincides with a monthly ovulating pattern. In perimenopause, things start to go a little bit erratic. And that's largely due to that our ovaries, we have less follicles, we have less eggs. They're becoming less responsive to the message each month for them to ovulate, and things become a little bit of a roller coaster. And it's that roller coaster of hormones that leads to a lot of the symptoms of perimenopause. Eventually, we reach our last period. We're no longer releasing eggs. And at that stage, our estrogen levels start to decline. And the bad news, that also leads to symptoms. So how do I know I'm menopausal? The diagnosis is based on history assessment. Blood tests are not really that useful. And that's largely because a blood test gives us an idea of what our hormones are like at the point in time that the needle is in our arm. And as that previous slide showed, things are fluctuating in perimenopause. So often hormones are completely normal in a perimenopausal woman. A doctor might carry out blood tests if she's ruling out kind of other causes for the symptoms, such as anemia or thyroid dysfunction, or if a woman is young presenting with menopausal symptoms. What are the symptoms of menopause? So every woman's different. Some women get little to no symptoms. Other women, unfortunately, get all of them. Symptoms last on average 7 years. The most common symptoms are hot flushes and night sweats, and they're experienced by 75%. But there's a lot of other symptoms around. And as this kind of questionnaire, which is a really small print, we use this in clinic setting a lot. It's called the green scale, and it lists off a lot of the common symptoms of menopause. So we don't just have hot flushes and night sweats. We have depression and anxiety. And unfortunately, women are 2 to 3 times more likely to suffer with depression and anxiety in menopause than any other time in life. We have the dreaded brain fog, loss of libido, joint pains, sleep disturbance, urinary frequency, changes in bleeding pattern. The list goes on. And this survey carried out by the British Menopause Society in 2016 shows kind of the impact these symptoms are having on women's lives. 50% are saying that their symptoms are impacting their home life. More than a third, the symptoms are impacting their work life. 50% are saying it's impacting their sex life. And over a third are saying it's impacting their social life. So it touches us in all areas of life. So how do I treat these menopausal symptoms? So there's kind of broadly three categories of how we treat things. There's lifestyle and complementary therapies, the non-prescribed treatments. There's hormonal medication, HRT, and then non-hormonal medication. So looking at lifestyle, certainly what we eat plays a role in our menopausal symptoms. Studies consistently show that eating a healthier diet, such as a Mediterranean-style diet, appears to reduce menopausal symptoms. Exercise, we know that moving is good for our cardiovascular, our metabolic and our bone health, but studies also suggest that regular exercise can reduce menopausal symptoms. It's advised to reduce or avoid triggers. The common triggers we know for worsening menopausal symptoms are alcohol, caffeine, smoking, spicy foods and stress. And it's a good opportunity for a woman to start using stress reduction techniques such as mindfulness and meditation. And then sleep hygiene. Lots of women know that during perimenopause and menopause, it can be really tricky to get a good night's sleep. But it's good to have all the other elements there that might help us. So having a regular bedtime routine, relaxation before bed, kind of avoiding screens, avoiding caffeine late in the day. We talked about exercise being good, but actually not going too strenuous on the exercise in the 2 hours before bed. And if we're lying awake at night, actually if we've been lying awake for more than 20 minutes, to get out of bed, go into a different room, let our body temperatures cool down, do some kind of quiet, relaxing technique, not looking at screens, and then returning to bed when we're feeling sleepy. On the non-prescribed therapies, there's a lot out there targeting menopause. My Instagram ads are constantly inundated, but I suppose herbal supplements wise, a lot of these things, unfortunately, there's not a huge amount of evidence. The trials are either small or the results are inconsistent. You'll commonly hear mention of black cohosh and St. John's wort, red clover, which contains isoflavones, and chasteberry or Agnus castus. Yes, some studies show that they can reduce menopausal symptoms, but it's important to bear in mind that they can interact with other medications, and there are sometimes safety concerns and concerns about the reliability of dose effectiveness. Isoflavones, these are found in soybeans, soy products such as miso, tofu, lentils, chickpeas. They are a chemical that's similar to estrogen, so they're felt to have a kind of weak effect on estrogen receptors. Some studies show that they can reduce menopausal symptoms. Again, not that reliable on the trials. And we do know that, I suppose, women who live in countries where there's large amounts of this in their natural diet, they do appear to have less menopausal symptoms. Vitamins, the general advice is that for vitamins, we should be getting it from our diet rather than supplement. The one exception for that is vitamin D, which we need for our bone health. We should be taking that because that comes from sunshine. And as today shows, we have not the sunniest of countries. But otherwise, vitamins for symptom control, again, inconsistent trials, possibly can reduce symptoms with vitamin B, vitamin E, vitamin D also, omega fatty acids and zinc. Acupuncture, a lot of women report that acupuncture helps with their symptoms. Again, unfortunately, trials are a little bit disappointing. That can be difficult to study acupuncture against the placebo because they still have to put needles in a woman when they're doing that placebo test. Cognitive behavioural therapy, a huge amount of evidence actually behind CBT, not just for dealing with psychological symptoms, but actually also for the physical symptoms of menopause, like such as hot flushes and insomnia. It's actually in trials one of the most effective treatments for poor sleep. So that brings us on to prescribed medications. Starting with the non-hormonal prescription medications, these can be really effective in managing the symptoms of menopause. Yes, they don't treat the underlying cause, they don't go near our hormones, but they can be really effective in managing symptoms. They might be suitable for someone who wants to take medication but can't take hormones or doesn't want to take hormones. They can also often be given with HRT, and some women actually might be taking some of these medications already. So these are the kind of commonly prescribed medications. I'm not going to go into all of them. SSRIs, SNRIs, they're antidepressants and anti-anxieties. Gabapentin, which is often used for nerve pain. Oxybutynin, a medication we use for overactive bladder. And clonidine, an old-fashioned blood pressure medication. All four of those have shown that they can reduce hot flushes and night sweats by about 50%. They do have their side effects, so they're not completely risk-free. Beta blockers is another blood pressure medication, and that can be used to treat the physical symptoms of menopause and also help prevent migraines, which unfortunately become more severe and frequent in a lot of women in perimenopause. Moving on to HRT. So this does deal with the underlying cause for symptoms. So HRT, the aim of HRT is providing a stable level of estrogen. So whether you're in that roller coaster of perimenopause or that declining level post-menopause, HRT is going to give you a stable level of estrogen. You'll find most women are on two hormones, estrogen and progesterone. And the reason for that is if you give estrogen on its own, it stimulates the lining of the womb. That constant stimulation over years could lead to cancerous changes. So we give progesterone to protect the lining of the womb. Lots of HRT out there. There's patches, gels, sprays, vaginal preparations, the coil, testosterone gel. It's a little bit overwhelming, the choice, but it's great that we have a choice. So figuring out which hormones. So I mentioned estrogen. Estrogen is the hormone that's going to do the hard work, treat the symptoms, has some nice long-term benefits as well. If we have a womb, we're going to give estrogen with progesterone. Some women will also take testosterone as a third hormone, which my colleague Aoife is going to talk about later on. You'll also hear, when we're talking about hormones, you'll also hear the phrase body identical. So unlike what Samantha was talking about in the clip, she mentioned bioidentical. It's a different thing. Body identical is a regulated medication. It's where the hormones are molecularly identical to the hormones our ovaries produce. Bioidentical is the less regulated stuff that the British Menopause Society gives out about a lot. Route, how we give the hormones, as you saw in the previous slide, there's lots of ways we can give it. We tend to, if we're giving estrogen, we tend to prefer to give it through the skin because it's associated with some less risks, but also it's down to a woman's own choice, what's going to be convenient for her, what's going to fit in with her life. The dose comes back, there's no reliable blood test to check how much hormone we need. So often a doctor might start on the kind of lowish dose and titrate up gradually depending on how a woman responds. And then cyclical or continuous, that relates to how we give the progesterone. The general rule is if a woman's still having regular periods, we're going to give the progesterone cyclically, which is often 2 weeks on, 2 weeks off, fitting in with her natural cycle and keeping a kind of regular bleeding pattern. So then this kind of, I've already touched on how we give estrogen. So you see there's lots of different options. Progesterone, there's also combination products of combination tablets with estrogen, progesterone, combination patches with estrogen, progesterone, and then testosterone through the skin also. So the benefits of HRT, the main reason we're going to give HRT is the improved quality of life. It's treating those symptoms, dealing with that impact our symptoms are having on a woman's life. There's cardiovascular benefits. Studies show that if we start HRT in women under the age of 60, within 10 years of her periods finishing, we can reduce heart disease and reduce death from heart disease. Bone protection as well. During menopause, we can have accelerated bone loss, which puts women at risk of osteoporosis. HRT can be helpful for that. And that Women's Health Initiative study that did show all the scary risks did actually show that it reduced the risk of bowel cancer in women. Side effects of HRT. So this is not a nice slide because it lists up all the side effects in one big list. We're treating a hormonal problem with hormones. A lot of the side effects remind women of kind of PMS or early stages of pregnancy. So like breast tenderness, nausea, changes in mood, acne, there can be bleeding changes. But the important thing to bear in mind is the side effects of HRT are often temporary. They resolve with time. Our body is getting used to this new hormone level that the HRT has introduced, and within 2 or 3 months, the side effects have subsided. So then, I suppose the concerns about HRT, there was that plummet in the use of HRT back in 2002, and yes, there are risks with HRT, but we just need women to be aware of them and to be informed. So kind of going through the blood clots. Yes, if we give estrogen by mouth, there's an increased risk of blood clots. However, that equates to about 1 case per 1,000 women. Giving estrogen through the skin does not carry any risk, and the choice of progesterone we give with the estrogen also influences blood clotting risk. Heart disease, I mentioned this already. So HRT started before the age of 60, within 10 years of a woman's period finishing, is actually protective. The kind of opposite, I suppose, is not true. So if we start it beyond 10 years, HRT doesn't cause heart disease, it just doesn't have any benefit. Stroke, again, starting HRT within 10 years of periods finishing shows no significant increase in the risk of stroke. Giving estrogen through the skin, no increased risk compared to a non-user, and again, the choice of progesterone can play a role. Dementia, so based on current evidence, women can be reassured that HRT is unlikely to increase the risk of dementia or have any detrimental effect on cognitive function. And then cancer. So ovarian cancer, current evidence suggests that there is a small increased risk of ovarian cancer with HRT, but this adds up to probably 1 extra case per 1,000 women using HRT. We touched on the endometrial cancer, the cancer of the womb lining, but if we're giving progesterone, we can largely cancel that out. Lung cancer and cervical cancer, there's no increased risk, and that moves us on to breast cancer and HRT. So looking at the results from the Women's Health Initiative, looking at all the studies that have been done since, we can say if we're giving estrogen-only HRT, so in women, say, who've had a hysterectomy, there's little change to no risk in the risk of breast cancer. Giving estrogen progesterone is associated with a small increased risk, but it's important to bear in mind that there's lots of things that we do in our lives that influence breast cancer risk, and HRT is one small part. Again, choice of progesterone may be kind of influence the risk. This is an infographic, kind of the British Menopause Society, and I think it explains, I know it's really small people, but it explains the kind of risk kind of clearly. So if you imagine if I had a room of 1,000 women in their 50s, unfortunately 23 of those women are going to develop breast cancer over a 5-year period. If we give all of those women HT, an extra 4 will develop breast cancer in those 5 years. However, take away the HT, give them all 2 glasses of wine to drink every night, 4 to 5 extra women will develop breast cancer. If they exercise regularly, 7 less women will develop breast cancer. Smoking increases the risk. A BMI over 30 increases the risk by 24. So this is important to bear in mind, and it can be good to kind of show to people, kind of demonstrate, look, yes, there's a small risk, but there's lots of things at a small risk. And it's important to bear in mind also for the women who have a family history of breast cancer. Unfortunately, 7% of women develop breast cancer, and that leaves a lot of sisters, daughters, nieces, granddaughters who have a family history of breast cancer. And again, there's been lots of research done on this, and for the vast majority of those women, the benefits of HT will still outweigh the risk, and it's something for them to talk with their doctor, or if they're part of a kind of breast family risk clinic, to talk with their doctors there. So in summary, every woman's journey is different through menopause. It's a personal experience, it's not just a group of symptoms. It's a time maybe to make changes, to think of kind of helping symptoms now, but also how can I help myself in the future. Treatment is really, there's lots of options out there. We should have it individualised, and all women should be able to access the information and advice about how to optimise this transition. Thank you.